Thanks everyone for the opportunity to present, and it's always a hard gig presenting after Peter, so I won't try and compete with him. Just make sure So I'm probably in a way preaching to the converted, because I think across Australia and New Zealand we've got pretty good coverage now in terms of cardiac arrest registries, but I just thought I'd take the opportunity to really emphasise how incredibly valuable they are at driving a quality improvement agenda, and just give you a bit of background on Ambulance Victoria's experience with our cardiac arrest registry. So to start with, just emphasising the value of registries in general, they're really powerful tools for describing healthcare, including the complications and benefits of therapies. They drive a quality agenda and really do help to foster a performance culture. They support more effective, efficient and appropriate care. Knowing that performance is being measured is incredibly motivational. You can allow them, through them you can provide meaningful data to clinicians, which encourages engagement. I think in AV we still have a way to go with that. One limitation we have with our hospital follow-up and ethics is that we can't give patient outcome data to the clinicians at the moment, because our ethics with hospitals is that it won't be provided to anyone in an identified format. So we're about to engage with over 100 hospitals that we have ethics approval for to try and allow us to provide that data back for quality improvement purposes. Registries can drive poorer performing areas to improve performance, and this is quite old now, but Graham Nichols' paper in JAMA estimated the number of additional survivors we would have if the poorest performing areas were lifted to the higher performing areas. They reduce costs associated with clinical trials, and we've managed to run quite significant clinical trials on cardiac arrest patients at AV with fairly small budgets, because we can collect a lot of the data through our registry. They verify if practice is in keeping with recommendations from guidelines, and they're really much more reflective of real-world practice. We monitor equity of access to care, monitor whether care is delivered in line with best practice, and they're relatively inexpensive and simple to maintain. That being said, a good quality registry needs to be well-resourced. And clinical trials often exclude high-risk patients, so they're often not reflective of your true patient population, whereas observational studies that you can do through registries are much better at reflecting real-life practice. And the most pressing areas for clinical quality registries are those important health areas that have variations in outcome, and cardiac arrest, as you've seen from Peter's slides, have significant variation in outcome. So it's definitely an area that warrants a clinical quality registry. That being said, and I think Peter mentioned this quite well, that unless you're actually using the data to measure and drive improvement, then there's really no point in having the registry. So there was a really good report released by Health Outcomes Australia, which really showed that you really need to use your registry data to measure and then drive changes. So value is only delivered through improved outcomes and greater effectiveness and greater appropriateness of care. So you really need to use the registry to look at the data, look at quality indicators, implement changes, and then improve outcomes through effectiveness and appropriateness. There was also a really nice report released by the Australian Commission on Safety and Health, Quality in Healthcare in 2016, where they took 5 clinical quality registries across Australia, and they did a deep dive into them to look at the actual cost benefit that was delivered from actually establishing a registry. And each of the 5 clinical quality registries improved clinical practice, and they showed that that was at a relatively low cost, leading to a significant net positive return on investment. So they estimated the benefit cost ratios of establishing the registry versus the improved outcomes that they got ranged from about 2 to 1 to 7 to 1. And they said that that would actually be even greater if all of these registries that they examined were made national. And the benefits that they saw were the tangible benefits, and they said there was probably a lot of intangibles in there around individual practitioner, cultural and system level benefits that even weren't measured. So, you know, if you're trying to lobby government to get some funding for your registry, there's some really powerful documents now that you can help, that you can access to help that. And I know in Victoria, in Australia, the government is recognising much more and more the importance of clinical registries, and also the importance of linking and harnessing the data from a lot of different registries that exist, so that there's, we have a new health insights area in the Department of Health, and they're driving that quite significantly. So, so obviously cardiac arrest is a key KPI for ambulance services. There's a general thought that if it's managed well, then other complicated conditions are likely to be managed well as in addition. Even modest improvements in survival, given its incidence, can translate to many lives saved. And I know the Resuscitation Academy has estimated that you need about 2.25 EFT per million population to establish a registry. I would argue that you actually need significantly more than that. You actually need to resource them quite well to have them running effectively, and for them to add the value that they can add. Obviously they need to adhere to standard definitions. There's the Utstein template, but even with standard definitions, it's amazing where I'm involved in the Australian resuscitation outcome. We're trying to establish a national Australia-New Zealand Epistree or national registry, and the debate around what definitions means is phenomenal. So try it, as long as you're within your registry, you're sticking to a standard that you're implementing consistently, then that's the main thing, because you can track your own improvements over time. You need to have full case ascertainment. It's absolutely fundamental. And I know with the AUSROC group, when we look at different incidence rates across the services that are providing data, it's very clear that some services don't have full case ascertainment, and that's fine. It's just something that needs to be recognised and learned from and built on. You obviously need to measure your critical variables, and as Peter said, you really need to collect data outside of survival to hospital. That can be challenging from some services. I mean, it's a very manual process in Victoria. We have over 100 ethics approvals that we have to give annual reports for, and we send monthly spreadsheets to over 100 hospitals to get outcome data. Some registries do it in a more aggregate fashion where they use death registries. That's okay as a start, but we know from our research that you actually overestimate survival significantly because your linkage with a death registry is not 100%. And we see that in Victoria when we do a 12-month quality of life survey for our survivors. We check the death registry before we contact them to make sure we're not ringing families of deceased patients, but we still invariably do that because the death registry is not 100% accurate with their linkage processes. So on to our cardiac arrest. Has anyone keep tabs of time? Can you tell me when I could talk about this forever. So the Ambulance Victoria Cardiac Arrest Registry, it's a clinical quality registry. It's used to drive performance improvement. It was initially funded by the Health Department, but we've had various funding journeys over time, and it's now funded as just out of our bottom line through Ambulance Victoria. It's classified as quality assurance by the Government Ethics Committee. We have a multidisciplinary steering committee with external members. We collect data on all cardiac arrests attended by ambulance, irrespective of whether resuscitation started. And we were lucky enough to sort of have the vision and start it back in as early as 1999. So we're getting up to 100,000 cases in our registry now. So that's incredibly powerful data to look for where our gaps are and where we can drive improvement. It's based on the Utstein template, but we actually collect a whole lot of additional variables, and it's dynamic. We're constantly changing it and adding variables as more information comes to light, or we realise that we have gaps. So we've just added a variable looking at the relationship of the person giving CPR to the patient, which will help inform public education. We've managed to get some more variables from our call taker centre, which is run by a different organisation in Victoria, where we're now collecting data on the actual time that the arrest was recognised and the time that instructions were given for CPR. And we're expanding our registry to incorporate Good SAM data so we can really evaluate the effectiveness of first responders. So it's a dynamic process that's changing quite a bit. And we have quite extensive reporting from it. And a lot of people sort of look at Ambulance Victoria and sort of say, oh, you're the gold standard, you know, it's so unfair, how did you do it? Well, it was a lot of hard work and it was a lot of lobbying, and it didn't just happen overnight. So we started with a letter to the Secretary for Health emphasising how fundamental this was. We got a little bit of money, like seed money, that was like a grant that went back to base, and we got other discrete funding. So it's been a constant lobbying and proving the value of it journey. So as soon as you can sort of demonstrate the importance and the return on investment, then you can build from there. But it doesn't just happen overnight. You need to be constantly lobbying for funding. Like I said, we gained ethics approval from over 100 hospitals. That was a huge amount of work. We've developed a data dictionary, and strict rules and guidelines for our data entry, but we still have weekly meetings with our data team, and they're encouraged to bring grey cases to sort of debate as to whether they're in or out. It's amazing even just deciding whether something's a cardiac arrest. So I think we're a little bit stricter than Seattle, so we don't accept patients who've had bystander CPR but then have a pulse on arrival unless they were defibrillated, because you can't be sure that they're cardiac arrests. But it's a constant area that needs to be regularly discussed, and I definitely encourage weekly meetings. And it's just been a journey in terms of the software that we've used, and from an organisational perspective, we've gone from paper PCRs to electronic PCRs. The perception was that would reduce workload, but in fact, you still need a similar amount of resources because you need to quality control everything that's electronically imported. So we do identify cases overnight by an electronic data filter. They get sent into a holding pattern, and then our data processors check everything to make sure that in fact they are a true cardiac arrest. Data is imported, and then it's supplemented with manual data entry, and every single field is quality controlled. Our data is at the moment it runs about 1 to 2 weeks behind the actual event. We do manual hospital follow-up, and since 2010, I think this is a really important add-on to our registry. We do 12-month quality of life surveys for all surviving adults. And I'd actually really like to move to our paediatric patients as well. So we do the short form 12, the EQ5D, and the Glasgow outcome scale, plus questions about whether they've returned to work. We actually have a paramedic honours student at the moment doing quite detailed study on predictors of return to work. And like Freddie sees in Denmark, 77% of our patients who were working prior to their arrest have returned to work at 12 months. So it's great data to share with people about that it's not futile to resuscitate these patients. We have extensive quality control, mandatory fields, combinations of relevant field validation. We randomly audit 10% of cases, and it's amazing what you can pick up from that. Like I said, our unclear cases are taken, we encourage the data processors to take those to meetings and discuss to make sure that we're consistently applying definitions. We look at hospital diagnosis, then look back at our kind of presumed cardiac etiology and see whether our coding looks like it was correct. And one of the big things is to compare with other publicly available statistics. So if your statistics are looking quite different from other ones, then it's rationale to go back and see why that is. So the RA mantra, and we've really tried to apply this for quite a number of years across Ambulance Victoria, and a big part of that has been having the executive and CEO support, but measure, improve, measure, improve, measure, improve. You can't improve unless you know what your baseline is, and so you really need to be collecting data on this. And from our perspective, the registry has been invaluable at monitoring initiatives and driving improvement and seeing how much of a step change various initiatives make. And this was just a paper published by one of our research fellows, Ziad, which you can look at in Circular Cardiovascular Quality Outcomes, but it is basically mapping our various initiatives and our improvements in bystander CPR and survival over time. And I know Denmark have published a similar paper that was really nice, mapping out improvement initiatives and impacts on survival. And as a result, we have seen significant improvement in our VFVT survival. So this is last financial year, but sitting around 34%. Still not up there with Seattle, and we're committed to implementing a lot of initiatives try and get at least 50% improvement, and I know Tony's committed to that, 50% improvement in survival, and we're lucky enough to have employed a resuscitation officer now, so we're having a really focused, organisational-wide focus on improving outcomes from cardiac arrest. And the registry will be fundamental in supporting that, identifying where the gaps are, and really driving improvement. This is just a graph out of our annual report for the 16-17. We're just finalising 17-18 now. But it really shows out the odds of survival from a shockable rhythm is, compared to when we first started monitoring this in the early 2000s, you're almost 4 times more likely now to survive to hospital discharge than over a decade ago. So, and interestingly, these statistics have been adjusted for the usual predictors. So we've adjusted for response time, bystander CPR, whether the arrest was witnessed, whether it was in a public place. So it's showing that there's something else as well going on there, which is likely related to the system of care, which is driving improvements outside of the Utstein predictors. So, but like I said, we're not resting on our laurels. We're very committed to developing that whole ethos that no one should die from a VFVT arrest, and where we've got a long way to go there. This just shows some of the quality of life outcomes that we see. This was, again, from our last annual report, and it's the short form 12. They do a physical component score and a mental component score, and this is what's called the standardised mean difference, so how different the cardiac arrest survival population are from their gender and age norms, in the equivalent norms in the population. And if it crosses 0, it shows that it's not significantly different. So their physical component score slightly less well than their age and gender peers in the population, but not significantly. And interestingly, they often report a better mental quality of life, and I think that's the kind of survivor attitude where I speak to a lot of these patients on the phone when our letters go out for our follow-up, and they're often extremely grateful for the life they have at the moment. So just a little bit of a summary around how we use our registry to contribute to change, so using the data to really drive improvement. We look to see, there was a while where there was quite a bucket of money from the health department that was allocated to improving survival from cardiac arrest, and various initiatives, and at the time Rural Ambulance and Metro Ambulance would lobby to get the money, and we really used our registry to do analysis to show the government which investment was likely to produce the most survivors. So it was very powerful for, again, lobbying for government funding. We use it to measure the impacts of programs like our 4 Steps for Life, our emergency medical response program with the fire brigade. We use it to identify where we should be locating our fire first responders, or gaps for public access DFIBs. We've done a lot of analysis around various system changes, so we looked to see what the impact was when we changed our dispatcher CPR instructions. We looked to see the impact of going to a computer-aided dispatch in rural areas, and we did, again, Ziad did this a while ago, we had a look. We had a clinical practice guideline change a few years ago where we moved to automatic rhythm interpretation as the first analysis, because there'd been a few missed VFVTs. And the registry has been extremely important for that, because we waited a few years and then we analysed and we showed that CPG change actually really impacted and decreased our survival. So we're about to go back to manual rhythm interpretation. But unless you have powerful registry data to see this, and the techniques to analyse that step change actually exists, then you wouldn't know that CPG change was actually detrimental. We'll certainly be using it to look at re-accreditation and with registration. There's probably going to be that you'll need with the authority to practice, you'll probably need certain exposures. So the registry will be used for that. And I know most people are familiar with Kylie Dyson's research, where she's looked at the number of arrests that paramedics have been to and the time since the last resuscitation, and shown a significant association between that and patient survival. So like up to 40% difference in survival if paramedics who had been to a resuscitation within the last 6 months and had more resuscitation experience. So all these sort of things then go into, well, how do we keep training? Is it simulation? Like, you know, we know in our service that paramedics are likely on average to see 2 arrests a year. So, you know, how do you keep, and that's that whole concept of low fidelity, high frequency training, which we haven't implemented yet in Ambulance Victoria. We've also used it to look at our dispatch grid changes, so you can do evidence-based changes, and then we looked at the impact of our revised clinical response model. We look at whether paramedics are transporting to PCI-capable facilities, and again, with our good quality of life outcomes, you can have meaningful conversations with clinicians around the futility or the lack of futility around resuscitation. We also use it extensively for providing feedback into the field. So we look at our team managers audit cases. We have like a limited occurrence category, which is if there's more than a 3-minute delay to defibrillation. But that being said, one of the real challenges in ambulance services is we have so many individual clinicians. So we have over 4,500 paramedics and over 500 teams. So providing like team level outcome data becomes really tricky with a condition like cardiac arrest because the numbers are just too low to be meaningful. So there's a real challenge there in terms of how you pick up outliers and how you report back to the service. This is just an example of some of our internal reporting where we give our regions their survival rates and we do a rolling 12-month and update every quarter. And again, we give them odds of survival by region, adjusting for factors. So this is an example where you can see Grampians, probably after you adjust for all the predictors, there's something going on there that we need to look at. So I won't go into, this was just really talking about the journey that we've had, but you know, it's now embedded in normal business. We use it to inform KPIs with government, and you know, it's something that we'll never, we'll never shut down now because it's so embedded and so used extensively in our system. Just finishing up, just to mention the AusRock Epistree, which most states and New Zealand are contributing to now, and I think it's a really important initiative to try and nut out that differences in survival across different communities and doing some meaningful risk-adjusted analysis to work out where are the gaps and what is that service doing better than us, or what are we doing to change outcomes. So I really encourage services to contribute to the Epistree. This is a kind of map of everyone contributing at the moment, but I know New Zealand and Tasmania have actually committed, not New Zealand, sorry, New South Wales and Tasmania have made a commitment that they'll start providing data as well. So I think that's a space that we'll be watching with interest and will be very helpful, I think, in driving an improvement culture on a national and international level. So thank you very much.